Hi, this is Brian Wormers recording a lecture from musculoskeletal trauma, especially focusing on fractures for medical surgical nursing for the University of Sioux Falls. So for our learning objectives, we're going to compare and contrast different types of fractures. We'll talk about musculoskeletal and neurovascular assessment. We're going to talk about collaborative management for patients with fractures. We'll talk about potential complications, and then of course we'll talk about some care that we're providing for these patients with fractures, including traction and external fixation. So fracture, by definition, is a break of the continuity of the bones, and it's going to impact mobility and sensation. It could either be complete or incomplete. So complete is across the entire width of the bone, or incomplete does not completely separate the bones. It can be described by soft tissue damage. Is it open or compound, or closed or simple? And that just means, is it going through the skin? Can you see the bone? Lots of different types of fractures with this one. So complete, all the way through; incomplete, not all the way through; closed, so non-displaced, so it's within the body; open, simple, displaced, so this is closed, it's still within the body, but it's not where it's supposed to be. It's not lined up. You can have open compound fractures going through the skin. Can get avulsions, can get comminuted. This is usually really bad. So you're getting a lot of pressure, a lot of forces cause this, and you get lots of little bone fragments with this. On the spine, you can get compression. On the head, you can get depressions like skull fractures. You can get green stick, which is more common in pediatrics. You can get oblique, going kind of diagonal. You can get spiral, which is a rotational injury, or an impact. This is usually like a fall or something. So lots of different types of fractures. Assessment, oftentimes patients are going to say, oh, it's got pain and tenderness and muscle spasms and lack of mobility. Objectively, edema, swelling, deformities, bruising, loss of function, and even some crepitus. So assessment-wise, so psychosocial, we're going to talk about how patients are going to cope with this, support, and how they're doing with this. Laboratory, nothing specifically confirms fractures, but we might be looking for causes of fractures. So if we're talking about vitamin D deficiency, calcium deficiency, tumors, different things like that, we might trend that with laboratory. So ESR or CRP looking for inflammation. Imaging-wise, X-rays are probably the most common way to do this, but you can get more specific with CTs and MRIs. Diagnostic-wise, guess what? They're going to have pain related to fracture and soft tissue damage with muscle spasms and edema. So we're going to try and reduce that. We can use different pain medications, reduce that, and make sure that the bones are lined up. Maybe use some traction. I don't see traction used a lot in a clinical setting. NCLEX still love to ask them questions, like especially bucks, traction. We'll cover that in a little bit. Otherwise, if it's unable to be a closed reduction, we might have to do an open reduction and an internal fixation with surgical management. So reduction, like I said, that's just proper alignment. Closed means it's non-surgical. We can do it in emergency department or in clinic setting. Open is surgical intervention. Fixation can be internal fixation, so these are plates, screws, those kind of situations, or pins. External, you're having some kind of external frame to support that bone, and you've got pins that go into that external fixation device. Traction, so this is commonly of lower extremities or even cervical traction, and you're just you're stretching it so that the bone can grow in a correct manner. There's skeletal, skin, and a balanced suspension. Like I said, we don't see this a ton. Can do casting, plaster, fiberglass. Fiberglass is more common. They're actually starting to even do 3D printing with plastic ones now, and that's kind of nice because it's lighter. So I haven't seen that around here yet for the 3D printing one, but just know that that's available. So other things that we're doing is immobilizing those bones, and that's why we put the cast on it. I have a feeling all of you know what a cast is, and have seen one at one point in time in your life. Types of traction, skeletal traction, so you got pins coming out of the bones or wires or tongs. And then we're hanging things off the bed and putting weights on these to try and stretch. Skin, so this is Buck's traction, so this is like a boot that they'd wear, and that fits on that leg, and that is attached to weights. With any of these traction things, skincare is important. We want to look at the site care, make sure that you're not getting breakdown of that one, make sure that the weights are appropriate, that they are what the doctor ordered. You cannot change weights on your own. Make sure that this patient hasn't slumped down in their bed and the weight's on the floor, because this does kind of hurt. I mean, number one, it hurts just by pulling on it, and number two, it can cause lots of cramping and spasms of your muscles. But frequently check on it, make sure that the equipment's functioning properly and that your patient isn't sabotaging themselves. With cast care, if you're putting casts on, make sure you're doing some of the basic stuff for fractures. So rest, ice, compress, elevate. If they've got a wet cast on, especially, so this is talking about the plaster Paris ones. Realize that this is going to be wet afterwards, so it's got to dry to be hardened and to be functional and protect that joint. Also, it's going to be heavy, so a lot of times we're doing more fiberglass casts. We're going to encourage finger-toe movement. We're looking for circulation, and we'll talk about that in a little bit. Do not stick things in your cast. So I've seen a variety of different things, including coat hangers and steak knives, because underneath it's itchy and you can't always wash it, clean it. You get dry skin, sweat, and patients really complain that it'll itch sometimes. So diagnostic-wise, we do want to watch for neurovascular compromises related to tissue edema or nerve bleeding. So we're going to be doing our circulation checks, movement checks, and sensation checks, commonly called CMS checks. So that's part of your neurovascular assessment. But think about your 6Ps or even 7Ps. So you get pain, point of tenderness, pressure, pulselessness, pallor, paresthesia, paralysis. The seventh one that I've heard of is pistol shot, so like a really rapid onset. What we'd be worried about would be compartmental syndrome, and so in which you get your fascia is really inflamed, and so you've got to cut that open to relieve the pressure, because what's going on is you get so much pressure that's actually compromising blood flow, and then the tissue is getting ischemic and dying. So there's your treatment. Medial incisions, lateral incisions of this, opening up that site. It's a medical emergency. And so they want to know about this really rapidly. So if you have anybody that's getting neurovascular compromise, so poor perfusion, dusky, covered extremities related to the casting, you've got to crack that cast, bivalve it, and open it up. Other complications for fractures, fat embolism, so especially in the long bones of like femur and such like that. So if they break that, they can get those fat globules that get released in the bloodstream. And of course that can cause like pulmonary embolism and different stuff like that. If they've got these, they can be really restless, have hypoxemia, tachycardia, hypotension, dyspnea, all these kind of bad things. So oftentimes we're using, treating any symptoms as ordered, trying to prevent failure and death, of course. So steroids may be given, trying to calm the body down. It's hard to break that fat embolism up, so they might have to go in after it, depending on where it's at and what it's all doing. Planning and implementation, so watch for infections. So of course we're going to be treating with antibiotics as appropriate. We're going to keep that site clean. Oftentimes we're talking about this, especially if it's open fractures or you're doing pins and you have external hardware. So with this, signs and symptoms of infection, you all know those. Red, tachycardia, warm, increased temperature throughout the body, drainage. So therapy is ordered, keep that site clean as possible, and then if it gets severe enough, we might even put a wound back on. Complications, so osteomyelitis, so that's infection of the bone in and of itself. So similar to all those other things, except the bad thing is within that bone compartment, it's hard to get the antibiotics in there. And so it's usually a long-term course of IV antibiotics that will often require a PICC line for it. If this is not being successful, it could be a surgical intervention in which they are injecting the antibiotics directly into the bone, as well as creating holes for the bacteria to escape. So diagnostic-wise, for your nursing diagnosis, you might have physical immobility related to acute pain. Outcome-wise, we really want to try and increase our mobility by promoting mobility with crutches, walkers, canes, therapies. We really do want to prevent complications from immobility, and you know what those are, as well as prevent falls. And make sure you're using the gait belt, make sure you've got the appropriate assistive devices as needed. That concludes this lecture. If you have any questions on fractures, please let me know.